Hello, I'm Sharon Karlsberg, a principal with ZS, a global sales and marketing firm, coming to you live from the ASCO 2016 conference. I'm here today with Dr. Edward Garon, Director of Thoracic Oncology at the Johnson Comprehensive Cancer Center at UCLA. Dr. Garon, thank you for joining me today. How are you?
I'm doing well. How are you doing?
Great. I know you've been very closely involved in many of the developments with anti-PD-1 therapeutics in the field of oncology. Perhaps you could tell us a little bit about your work in lung cancer?
A lot of my involvement has been through clinical trials, particularly looking at pembrolizumab. And when we looked at that in a large phase 1 experience, we found that the degree of expression of the biomarker PD-L1 by immunohistochemistry was associated with an increased response rate when the PD-L1 expression was higher, and that actually translated to improvements as well in progression-free survival and overall survival.
And I know we've seen very promising data with both pembrolizumab as well as nivolumab. Not all the new agents in development, however, require a companion diagnostic, a PD-L1 biomarker test. Is that right?
Well, interestingly, the new agents in development largely are working with tests that would evaluate PD-L1 expression. The one agent that does not require PD-L1 expression at this time is nivolumab. So nivolumab is the first approved PD-1 inhibitor. It was approved initially based on data from squamous cell carcinoma. And there, when evaluated for PD-L1, the benefit of nivolumab over docetaxel was seen in patients who had high PD-L1 expression, low or no PD-L1 expression, really. And so that approval has not required a PD-L1 assay.
So in this case, where we have one agent that is approved for use with a companion diagnostic PD-L1 biomarker expression and another agent which is not required, where do you see the benefit of PD-L1 testing falling?
So in the current time frame, there are many patients for whom a PD-L1 test is probably not required. So for instance, a patient who has had multiple prior lines of therapy where your anticipation for an additional therapy is extraordinarily low, PD-L1 expression may not help you select a patient in that situation because it may be very clear that their best option is a PD-1 inhibitor. The other thing that I think is important in all of this is that the field is eagerly awaiting data in the frontline setting from both pembrolizumab and from nivolumab. And those data sets are based on PD-L1 expression. So if those data sets show that there is a group of patients who benefits from PD-1 inhibition in the frontline setting, more so even than standard frontline chemotherapy, then I think we will be in a situation where regardless of other things, we will be testing for this to identify patients who should receive this in a frontline setting.
Okay, so knowing what you know about the data today, it sounds like there are two situations. In the second line, or patients who've previously been treated, there may not be a need to test because they may have received prior treatments. In the frontline setting, many of the new agents are being studied with that test built in as part of patient stratification.
In general, I would agree. In a second line setting, there are probably patient populations where it would be helpful to know whether or not they have PD-L1 expression and at what level. And I think that what many in the field are looking at is getting this at the time of their initial diagnosis. Now, that I think will become clearly standard if the frontline studies in biomarker selected populations come back as positive. But it can be helpful in decision making regardless. There are many scenarios where the likelihood of a patient responding would be important to know. There is good data that PD-L1 expression does a good job of predicting patients who will benefit from PD-1 inhibitors. It just, when negative, does not exclude the likelihood that those patients also can benefit.
Those in the community who are faced with this dilemma, what would you say in brief are the reasons to test for PD-L1 expression today for common community practice?
I think the reason to test is to help identify how likely a patient is to benefit from the drug. This can give both prognostic information when one starts the agent and can allow you to prioritize your potential therapies in the most logical way for a given patient.
Makes sense. And are there reasons that others might say or you could envision for not testing today for PD-L1 expression?
Again, there are many patient populations where when one evaluates the the likelihood of response, even if you don't know the result, or even if the result were negative, as compared to the alternate therapies, that one could say it really doesn't matter. So yes, I certainly think that there are rationales to do that, but I think that it is likely that we will be evolving to a place where PD-L1 serves an important purpose for prioritizing when one would use a PD-1 inhibitor or PD-L1 inhibitor in the care of a patient.
Thank you, doctor.
Thank you.